morning. So today we are at the third World Congress on Cardiometabolic Syndrome, which is held in Mumbai in the year 2024. My name is Amrish Agrawal, and it's a pleasure for me to have Dr. Tahir Kuzaim, consultant intervention cardiologist at Fujira Hospital, United Arab Emirates. In this meeting, Dr. Tahir Kuzaim will bring his interesting perspective regarding the deadly combination of acute coronary syndrome and dyslipidemia. So, Dr. Tahir Kuzaim, please can you just tell us that the dyslipidemia is extremely common condition. I mean, everybody is checking their lipids a couple of times a year, but you as an intervention cardiologist is dealing with acute coronary syndrome day in and day out. So, how do you link these two things together?
Okay, thank you. Actually, it's my great pleasure to attend and participate in Third World Congress for Cardiometabolic Medicine. So, as you mentioned, Dr. Amrish, that there is a combination between dyslipidemia and coronary artery disease in general, not only acute coronary syndrome. And we know the risk factor for development of coronary artery disease in general for all population, whether male or female, old age, young age. There is multiple risk factors, and the strongest risk factor is the presence of hyperlipidemia or dyslipidemia. And there is a strong relationship. The highest the LDL or abnormal lipid, the highest incidence of development of the coronary artery disease. So our focus today on the treatment of dyslipidemia in this type of patient, the patient who have acute coronary syndrome and they have at the same time dyslipidemia. We know that many people, as you mentioned, Dr. Amrish, that many people, they have dyslipidemia, but not all of them, they should be treated like the patient who have acute coronary syndrome. I mean, the patient who have acute coronary syndrome, which means acute myocardial infarction or angina, they should have their lipid profile as low as can be achieved. Not like the other people who have only dyslipidemia, then these people can be treated simply. While the patient who have acute coronary syndrome, we need two things from them. Number one, we need to achieve the lowest level we can to prevent the second attack of acute coronary syndrome. We know that acute coronary syndrome now, it is very prevalent. It's affecting any age group actually, and the mortality and morbidity from the disease now is very common. And unfortunately, despite all the measures we have, all the medicine, all the investigation we have, still we didn't achieve the target in most of this population.
So I understand from you, for our general audience, that the target level for the patient with acute coronary syndrome is not the same level as the target patients without acute coronary syndrome. So would you like to tell our audience what target level we want to reach in the patient with acute coronary syndrome, or do we want to even reach lower than those targets?
Yes. So in acute coronary syndrome, the latest guidelines, whether European or American guidelines, they said the LDL, you should achieve it to reduce the level of the LDL, which is the bad cholesterol, 50% from the baseline of the patient before acute coronary syndrome to reach less than 55 or even 50 milligram per deciliter. Okay, so you have to reduce it from more than 50% reduction to achieve it less than 50 or 55 milligram per deciliter. This is the first attack. Now, with the patient have recurrent attack, you have also to reduce more than. You need to achieve it even less than 50 or 55. You have to reduce even less than 40 milligram. Because once you develop the acute coronary syndrome, this means that you have abnormal lipids. So you need to be very aggressive in managing the lipid profile and in managing dyslipidemia in the patient who have acute coronary syndrome, not like the general population who have only dyslipidemia or hypertension. In this population, there's certain number you have to achieve it, but not necessary to be very aggressive. However, in the patient who have acute coronary syndrome, which by definition is angina or acute MI, you have to reduce it as low as you can. Even sometimes they say if you reduce it to the level same like the level of the infant, I mean the LDL to be reduced the same level of the infant or child people, it is very protective in this patient.
So I see. So what I understand from you that the response is not a binary response, 55 or more than 55. Even less than 55, the response is graded.
Yeah.
So if you have a patient who's on having an acute coronary syndrome or a myocardial infarction, and you give them the medications, whatever medicines you want to give them, and their LDL cholesterol level comes down to a very low level. So would you stop the medicines? What you will do for them? And would you like to keep float it up, or would you like to continue at the same low level of the LDL cholesterol?
So this is what we looking now actually in the management of the patient who have dyslipidemia and acute coronary syndrome. So if you give two example, the patient who have LDL 100 milligram and the other patient having LDL 150, and both of them got an acute MI. So if both of them, you should reduce it less than 50% from the baseline. So 50% from 100, it should be 50 milligram. 50% from 150 milligram, it will be 70. But even the patient who have 150 milligram, when you reduce to 70, is not enough. You have to reduce less than 50 milligram. Now, once you reduce it, whatever you reach the level, it is better for further protection, not for the first time, but for the further protection. Because if the patient got acute MI at 100 milligram, if you reduce it to 50 milligram, the chance will be reduced, but not that too much. So you need to reduce even more and more. So if the LDL achieved the lowest level you can, this is safe and no need to stop the medication. However, in clinical practice, what we are doing, we are trying to achieve the LDL less than 50 milligram and not as much as low. Keep it probably around 40, 30. This is a safe and without any side effect.
Good. Thank you very much. Now, would you tell our audience what type of therapies or what type of ammunition even in your pocket to control the LDL cholesterol level?
Yeah. So there are now many medication available to treat LDL cholesterol, but the guidelines stated clearly to start with the first type of the medication, which is called statin. So statin is HMG co-reductase inhibitor, to give them the dose of the statin and wait, okay? So you have to wait during the acute coronary syndrome for 6 weeks and repeat the LDL. If you achieved more than 50% reduction to the level less than 55 milligram, then it's okay. Otherwise, you have to add other medication. So other medication like ezetimibe. So ezetimibe can be added to the statin and wait also for another 6 weeks and repeat the lipid profile again. If you achieve the target, it's okay. If you didn't achieve the target, then you have to add the other medication, which is PCSK9 inhibitor. Now we have two types of PCSK9 inhibitor available in the market, and also wait, because each medication has a certain level of the reduction. Statin, it will reduce the LDL probably 30 to 40%. If you add ezetimibe, probably it might reach 50%. However, if you add PCSK9 inhibitor to them, you will achieve more than 60% reduction from the baseline of the LDL. If you fail, then you have to combine all of them. Now, there are certain situations when you cannot follow this protocol. So as I say, the statin, then combined with the dual combination statin ezetimibe. If there is no response, then triple combination statin and ezetimibe and PCSK9. But certain population, they cannot tolerate. For example, if you give the patient statin, we know that statin associated with many side effects like muscle weakness, myopathy, and myalgia. Some people, they cannot tolerate. So you can combine early, even before going to a high dose. Early, you can combine immediately statin with ezetimibe or statin with a PCSK9 inhibitor. Now, other molecules now started to appear in the market, like the drugs that work on the genes or DNA molecules, like inclisiran. Now it's started to be available, but these drugs probably didn't studied well in the management of acute coronary syndrome.
Thank you very much. Is it a harm to lower the cholesterol levels to a very low level, because we all know that the brain is all big amount is fat, the babies require fat. So you can give some audience some guidance about if the cholesterol level comes to very low level on the medications, but you should worry about it, or they is perfectly safe?
Actually, the study, no study showed it is safe to reduce the LDL below 25 milligram per deciliter. Okay, so but all the talk, all the recommendation now to reduce as much as you can, but there is no safety below 25 milligram per deciliter. So probably you have to stop at 30 or 25 milligram per deciliter.
Thank you very much. So from your talk, if I want to summarize for you, would you like to summarize the take-home messages for the audience? What you would like to, how you want to link dyslipidemia and acute coronary syndrome? Would you like to summarize to our audience?
Yeah. So in general, dyslipidemia is the strongest risk factor for development of coronary artery disease, particularly acute coronary syndrome. So is the risk factor is here, you have to treat it. You have to treat it as aggressive as you can, and there are multiple options. Start with the high dose statin. If there is no response, then add ezetimibe. If there is no response, then you add a PCSK9 inhibitor. Most of the time, once you add PCSK9 inhibitor, the LDL will reach the target.
I see. And also, we would like to add on your behalf that there are no side effects of bringing the LDL cholesterol level to low levels. You will still get advantage. The response is graded from very high level to low levels.
Sure.
Thank you very much for your attention, Dr. Tahir. It was really a pleasure to have you on this talk. And the audience who are listening to this talk, they will benefit from this immensely.
Thank you very much.
Insights from the world's best medical minds. You are watching therightdoctors.com.